for I think 3.5 years. We might even be close to 4 years now, Ashley. And every time we partner with the Women's Fund, every speaker is a dynamic speaker, and the topics are so relevant to what we're experiencing in our everyday lives. And it's a pleasure to have Dr. Mazoon come back because we've had a chance to host her before. And with the way that our lives have changed in the past year, this presentation is going to be, I think, even more salient than ever. So thank you for allowing us to continue working together with the Women's Fund. And I'll turn it over to Kayla. I think she has some words and the formal introduction for Dr. Mazoon.
Thank you so much. We at the Women's Fund have thoroughly enjoyed working with you at UHD, and we're very excited for this presentation. Last time we had Dr. Mazoon with UHD, we were talking about the flu shot. And so today we are going to be talking about COVID-19 vaccines. But I just want to give a brief little introduction here. So for those of you who are not familiar with the Women's Fund, we are a not-for-profit organization in Houston, and we provide women and girls with the tools they need to be advocates for their health. So we do this through focused seminars, curriculum-based classes, and publications. You can visit our website, thewomensfund.org, to find out more about what we do and who we are. And then I will have an email address at the end of the presentation where you can contact us as well if you have any questions or if there's anything that we can do for you. So our guest today is Dr. Melanie Mazoon. And just to give you a little bit of information about her, after earning her medical degree in 1982 from the University of Texas Health Sciences Center at Houston and completing her pediatrics internship at the University of Kentucky in 1983, Dr. Mazoon returned for her residency at the University of Texas Health Sciences Center at Houston, finishing in 1985. She is the managing physician for immunization practices at Kelsey-Seybold Clinic. She's a member of the Texas Pediatric Society, Houston Pediatric Association, International Society for Travel Medicine, the Immunization Partnership, and the American Academy of Pediatrics section on breastfeeding. She's also a fellow of the Academy of Breastfeeding Medicine. Dr. Mazoon is married with 2 grown children. She enjoys gardening, sewing, tutoring adult study groups, and teaching children's classes. So we are very, very grateful to have Dr. Mazoon here today to give her presentation. And I'm going to go ahead and turn the floor over to her at this time.
Thank you so much for having me. It's always a pleasure to speak to any group in the public about vaccines because I think they're often a bit misunderstood and people are unnecessarily afraid of them. So hopefully I'll be able to answer your questions today about the coronavirus vaccine. Next slide. Yeah. So I think part of the issue is that people need to know what are viruses and germs in general. And so most viruses and germs are just some genetic material covered with a protein coat. And so our bodies are really fabulous at recognizing foreign proteins, non-human proteins. And when we become immune naturally to an illness, we are actually recognizing the bacterial protein code or the viral protein code and learning to kick it out of our body. So what is a vaccine then? A vaccine is actually just a protein that mimics the outer coating of a virus or bacteria that we know can cause serious infections without any of the viral DNA inside for the most part. There are a few older vaccines. Older vaccines are usually killed bacteria. They used to take the whole diphtheria bacteria, for example, and just kill it with formaldehyde and purify it and then inject that. But newer vaccines are just imitations of those protein coats that germs or viruses carry. Occasionally, we still use some live virus vaccines. Those viruses have been treated poorly, I'll say. They've been damaged in order to make them ineffective in causing illness, but they're still alive. They're weakened and unable to do to cause you harm. And so that's what vaccines are. And all vaccines teach our immune system to recognize these foreign proteins so we can eliminate them from our bodies before the germs can make us sick. Next slide. So these new COVID vaccines, the messenger RNA types, we now have a third one, which I'll explain a little more about later, but the messenger RNA vaccines, I think, have caused a little bit of concern among people because they are a newer type of vaccine. Actually, this type of vaccine has been studied for well over a decade, and it is something that we're now applying to infectious diseases, but it's been studied in terms of preventing cancer and other types of immune system stimulation. So messenger RNA is made by you in all of your cells all of the time. DNA is our genetic material, of course, and DNA contains everything we need to make a whole human. What messenger RNA is kind of a little stencil of part of the DNA. So the DNA opens up, and the messenger RNA is a little copy of a portion of the DNA that is needed to make proteins. Most of the time, the proteins that our cells are making are proteins that produce us. Hemoglobin, keratin for our skin, myelin in our muscles, myoglobin in our muscles. Myelin is in our brain and myoglobin in our muscles. So these are proteins that help our body function and form our body. And these messenger RNA vaccines are basically using our cells to make spike protein from the coronavirus. You can go to the next slide, please. So the spike protein on the coronavirus is kind of an interesting protein. That protein actually fits a receptor on our cells called the ACE receptor, and that is what allows it to infect our cells. So viruses generally are just kind of packets of protein that have viral DNA or RNA inside, and they attach or latch onto a cell, and then they squirt their genetic material inside and take over your cellular machinery in order to make more baby viruses. And so these messenger RNA vaccines are in some ways imitating viruses. They are the spike protein messenger RNA only, not the whole viral RNA. And they are basically enveloped in a fat globule so that your cells can take it up, can absorb that fat globule, and then the messenger RNA is in your cell, and it makes just the spike protein. The spike proteins that it makes are then expressed or put on the surface of the cell, which then is picked up by a local lymph node that says, hey, that's not human protein, and then develops immunity to it and stimulates antibody production. So it's a kind of a complicated process, but it's really the same natural process that your body uses to fight any infection. It's just that very clever scientists have figured out how to modify that process and make a very safe and effective development of immune responses to that spike protein without having to have the virus at all anywhere near you. And so in the future, your body already knows that protein is a non-human protein and is prepared to kick that virus out when it shows up. Next slide. So everyone has been concerned about, how did they make it so fast? And usually vaccine producers are self-funded. The pharmaceutical company has to come up with enough money to produce these vaccines, and they're not really under much time pressure to produce a vaccine. This pandemic has changed that because, it's killing so many people and causing such injury to our entire economy that the government funded vaccine companies to produce vaccine, and not only funded them to develop it, test it, find out if it works, but also funded them to produce large quantities before they even knew that it would work. And the reason they did that was they wanted to be able to distribute the vaccine as soon as it was proven that they were safe and effective. And so, for example, this newest vaccine, the Janssen or Johnson & Johnson vaccine, they already have millions of doses stockpiled and ready to go, so that now that that new vaccine has been approved or has received emergency use authorization, it's going to be able to be distributed really quickly. And so, without it, people have likened it to kind of like swimmers. You are either swimming in the same lane or you're swimming a relay. Usually vaccine production is like a relay. We do one step and then we do the next step, and nobody would even produce vaccine until they had some efficacy and safety studies. They certainly wouldn't produce a lot of it for distribution. In this way, the government has provided enough funding to these companies that they could have the vaccine available once it was shown that it was going to work. And also a lot of the sort of bureaucratic steps of getting things approved usually take a long time and were fast tracked because, time is of the essence if we're going to save lives. In addition, there were high rates of infection in our community. So instead of having to wait around for people to get exposed to something that's not very common, this virus, the coronavirus, has been very common in all of our communities. And so it was very easy to determine that people who had received these vaccines as they were being tested were not getting sick at the rates of people in the control groups who did not get the vaccine. Next slide. So the best way to find out if something is safe is to test it in a large number of people, because bad things happen to people all the time. Car accidents or heart attacks or cancer diagnoses, whatever it is, those happen all the time in a large population. And so if you are going to study a vaccine, you need to study it in a large group of people. Most of these vaccines were studied in upwards of 30,000 people, and half of those or a third of those received no vaccine, and the other half or 2/3 received the vaccine. And then they compared outcomes in those two groups. And so that's the way to find out if vaccines are going to cause a bad effect. Individual stories about outcomes that are scary that you might hear, really, you can listen to them and think, is that plausible or not? But you really shouldn't accept as fact that something was caused by a vaccine, some bad outcome was caused by a vaccine, unless it's shown in a large group, large population that's really the truth. Because things are often associated in time, but not causing each other. And so just an example of that is, I put my seatbelt on every time before I get in the car. And if I have a car accident today on the way home from work, I'm not going to blame the seatbelt, because those two things are associated, seatbelt riding and being in cars, but not necessarily causing car accidents. And so lots of things are associated in time without causing any ill effects. So next slide. So we're also following everybody who gets these vaccines. And, so they were studied in populations in the tens of thousands. Now we have tens of millions of people who have been vaccinated with these vaccines. And the good news is that we're following them very carefully. The bad news is my phone is getting a phone call from some spammer. There we go. The good news is we're following these people very closely. So everybody who gets this vaccine is encouraged to enroll in this program called V-Safe, everybody who gets it in the US. And this is a program that allows people to report everything that they think might have been caused by the vaccine, whether it's nervousness, tingling, their car accident, a heart attack, whatever it might be. So they can report any possible bad outcome so that they can be followed up on, and so that we can know in a very timely fashion if this vaccine is having bad effects. They are also following with VSafe everybody who gets this vaccine who is pregnant so that they can follow their pregnancy outcomes. So while the vaccine wasn't studied in pregnant women per se, there are many pregnant healthcare workers who've already received this vaccine, and their pregnancies are being followed to make sure that our concern that, or actually our reassurance that it is likely to be completely safe in pregnancy is in fact the truth. There are older programs that monitor vaccine safety, and those are still in place. There's one called the Vaccine Adverse Event Reporting System, VAERS or VAERS, and that is a passive reporting system. People have always been able to report to the CDC that they had an outcome that they think was caused by a vaccine. For example, flu vaccines that are given too close to the shoulder joint actually can cause some irritation in that joint and some temporary arthritis. That's from giving the vaccine in the wrong spot, not giving it in the muscle, but giving it into the joint. And that's something that's commonly reported in VAERS when people are vaccinated too high up. But anything can be reported. And so that's a system that's been in place to study things like autism and, other concerns, multiple sclerosis, and, people who do report something that they believe was caused by the vaccine. That system follows those people and does the necessary due diligence to determine whether it is likely to be caused by the vaccine or not. Which, by the way, autism and multiple sclerosis are not felt to be caused by vaccines. There's also the Vaccine Safety Data Link, which follows about 350,000 people in the United States. And they're followed anonymously, but this is reporting from large healthcare systems with electronic medical records, and it's de-identified data on people who get vaccines and then what sorts of diagnoses pop up in those same people's charts over the next whatever period of time they decide to look at. And so that Vaccine Safety Data Link is the best, before this VSafe, has been the best program for us to look for unexpected bad outcomes, things that people haven't thought might be caused by vaccines. And to date has shown that vaccines are very safe and effective. And really most bad or most side effects of vaccines are going to occur in the first 6 weeks. And there are no long-term illnesses that have ever been shown to be caused by vaccines. Next slide. Did you skip one or did you just go? Yeah, so there are some people who should not get this COVID vaccine. If you have a severe allergy to a component of the vaccine, I'm sure you've all heard that some people have developed severe allergic responses to this vaccine. And those responses are called anaphylaxis, and they usually involve wheezing, swelling of the tongue or lips, severe itching all over, and often require the administration of an adrenaline shot or epinephrine pen. And so anyone who has an allergy to one of the parts of the vaccine, of course, if you have it injected in you, that allergy is likely to cause a reaction. People who have a history of severe allergy to any vaccine or injectable medication need to determine, what that reaction was due to, and make sure that it wasn't due to something that's in the vaccine. So this a bit of advice is changing a little bit, because we now know that polysorbate and polyethylene glycol, or PEG, are likely the causes of these allergic reactions to this newer vaccine. The rate of severe allergy to vaccines is usually about 1 in a million, and with these vaccines, it's more like 1 in 100,000. And so that's still not at all common. But those people who have a concern about that need to discuss it with their allergist or with their physician before they're vaccinated, or if they know they're allergic to those two components, polysorbate or PEG, or if they have an allergic reaction to their first dose of this vaccine, then they should not get another dose. For right now, people younger than 16 years of age cannot get this vaccine unless they're part of a vaccine study trial. Next slide. So we also don't want people coming into a big vaccination hub to get the vaccine if they are currently isolating or having symptoms of COVID. We don't want the people who are there, who are at high risk, who are there to get their vaccine, to get sick with COVID while they're waiting to get their vaccine, or for the people who are giving out the vaccine to be exposed unnecessarily. So once you're finished with isolation and your symptoms have resolved, then you can go ahead and get the vaccine. Most people in general, across the population, regardless of their risk group, are going to be able to get this vaccine once their priority group comes up. So there's not a huge number of people who have contraindications to this vaccine. Next slide. So what is in the vaccine if you're worried about allergies? So this is the list off to the left-hand side. There are no eggs, gelatin, latex, or preservatives. Those are things people are commonly allergic to or opposed to having in their vaccines. The PEG and the polysorbate are the likely causes, as I said. Next slide. These other things that are in the vaccine are messenger RNA, of course, because that's what's protecting you from this virus. Lipids are that fat globule I was talking about. So they protect the messenger RNA so it doesn't break down before it gets into the cells. And there are 4 different lipids in the Pfizer vaccine and 3 in the Moderna vaccines, one of which is cholesterol, which is something your own body makes and which we eat all the time. And so we think it's the polysorbate and the PEG that are the issue. Next slide. There are also some salts and amines. Those are things to keep the pH of the vaccine similar to body pH and to prevent breakdown of the messenger RNA. And then sugar, which the sugar is actually in there just to keep the bubbles of fat from sticking to each other so that they stay maintaining their little covering of the messenger RNA. So those are the only ingredients in the messenger RNA vaccines. Next slide. What the vaccine doesn't contain, so it doesn't contain any fetal material. It doesn't contain, so these are all actually myths or misinformation which is out there on the web. So it doesn't contain fetal material. It doesn't contain DNA. And in fact, the messenger RNA can't get into the nucleus of your cell to affect your DNA. It doesn't contain any antibiotics or blood products. There are no preservatives like thimerosal in it. There's no gluten or egg proteins for people who have to avoid those. There are no pork products, and there are definitely no microchips. Next slide. So turning to people who can get the vaccine, which is most of you. People can get the vaccine after they are in the category, the risk category that they can receive the vaccine. So in Texas, the current groups that are getting the vaccine are called 1A and 1B. And 1A is people over 75 and healthcare workers and people who are, basically first responders and at highest risk because they're dealing with infected people or because they're at the highest risk for death from the virus. And 1B, which is people over 65 and anyone from age 16 through 65 who has what we call a comorbid condition or a predisposing condition. So obesity, diabetes, there's a variety of different things that put people at risk. And so the groups those groups all contain some pregnant or breastfeeding women, and the vaccine has not been tested, as I said before, in these groups. But because of the way the vaccine works, messenger RNA is a very short-lived molecule. It produces the proteins and then it falls apart. If messenger RNA was a long-lived molecule, we would all be sick from that because we'd have way too much keratin or way too much hemoglobin or whatever around. So that's a natural quality of messenger RNA is that it's very fragile. And so the vaccine basically goes into your muscle and it affects some cells there. And very soon after you get it, it will be completely gone. And so it's not transmitted through the bloodstream to get into breast milk. It's not going to be transmitted to the fetus in the womb. And so we don't suspect that there will be any harm caused to infants or through giving pregnant or breastfeeding women this vaccine. And in fact, as I said, we've been following pregnancies, and so far there have been no signals of any kind of concern about being vaccinated when you're pregnant or breastfeeding. There are people who have immune compromising conditions. So, again, diabetes is an immune compromising condition, but there are others like AIDS or multiple sclerosis or different sorts of immune system dysfunction, severe combined immune deficiency, things like that. And if your immune system is not very effective, like someone with AIDS, then you may not develop strong immunity, but you're unlikely to be harmed by the vaccine. And it would be safer for you to get the vaccine than to get the illness. If your immune system's problem is something like multiple sclerosis or autoimmune arthritis, those sorts of illnesses can be triggered by any kind of infection. And there's the potential that they could be triggered by these vaccines. But again, it's much more likely they'd be triggered by an ongoing infection that affected your whole body than by a vaccine. So we are not restricting this vaccine really hardly at all. There is in the EUA or emergency use authorization paperwork some talk about, people on anticoagulants discussing this vaccine with their doctor before they get it. That's really just because it's an injection. And as with any injection, if you're on an anticoagulant, you might have some local bruising or even a little bit of bleeding after an injection. So next slide. Again, the people with allergies, we want to have a little bit of a special procedure. So people who have an allergic reaction, the anaphylaxis to something like bee stings or peanuts, they can get the vaccine, but they ought to wait for about 30 minutes after they get it before they leave the vaccination area. And the reason for that is if your body knows how to have anaphylaxis to one kind of protein, it may have an allergy to this PEG or this polysorbate without your knowing it. PEG and polysorbate are present in over-the-counter laxatives and other kinds of medications. So just because people might have that sensitivity and not be aware of it, if you have a history of anaphylaxis to anything other than a vaccine or injectable medication, you can go ahead and get this vaccine, but you need to wait for 30 minutes. Again, if an injectable medicine has given you anaphylaxis before, you can kind of cross-reference the ingredients. You're more than likely going to be safe to get this vaccine, unless the injection that caused your reaction was this vaccine. But again, you should wait for 30 minutes, and you may want to talk it over with your allergist. If you're pregnant and get this vaccine and you develop a fever after vaccination, we do encourage you to take some acetaminophen or Tylenol. And the reason for that is we know that high fevers, which this vaccine doesn't tend to cause high fevers, but high fevers in pregnant women can cause birth defects. And so we try and prevent pregnant women from sitting in hot tubs, and we try and treat their fevers whenever they have a fever to keep their temperatures low. And people who have recently had COVID-19 and were treated with antibody-based therapies, the monoclonal antibodies or plasma, we want those people to wait 90 days before they're vaccinated. We still want them to be vaccinated because we want them to have lifelong immunity or as long immunity as possible so that we can get this pandemic under control. And there have been cases of people who've gotten COVID-19 more than once. And so we do want them to be vaccinated, but the 90-day period is because antibodies can last that long. So that also brings up the question of if you've just recently had COVID-19, you will have some of your own natural antibodies, not ones that were infused, but your own natural antibodies. And those people are also safe for about 3 months or 90 days from being reinfected. And so people who've had COVID, they can actually get vaccinated as long as they're not contagious. But the thought is that if they wait 90 days, they're a little less likely to have a really marked local reaction to the vaccine, and they're unlikely to get sick during that waiting period. So if they would like to wait the 90 days, that's fine. They can be vaccinated sooner if that's what they would prefer. Next slide. So I think I pretty much talked about this. We do want people who got another vaccine, for example, adults who've gotten a shingles vaccine, we want them to wait 14 days before they get the COVID vaccine, and to wait 14 days after they get the COVID vaccine before they get another vaccine. And the reason for that is really, we just don't want to be confused about, if they do have some sort of adverse event, we want to be sure we know which vaccine we're trying to sort through to see if it caused an adverse event. Again, most side effects from vaccines are going to occur within just a few days, and certainly within 2 weeks. And really, nothing has ever been shown to be caused by vaccines longer than 6 weeks out. Next slide. What are the side effects? You can expect some side effects from these vaccines. That's actually because they're pretty effective. So when we have a sore arm after a shot, or we feel a little bit under the weather or have a little low-grade fever from our flu vaccine, for example, that's not because we have the flu. That's because our immune system is responding to the vaccine. And so it's actually a good thing to have a little bit of a side effect from a vaccine, because that way you know it's working. The most common side effects from these messenger RNA vaccines are fatigue or being tired, headache, muscle aches, and sore arm and redness at the site. And for these vaccines, they really do cause the lymph nodes in your armpit to react. So just in your armpit on the same side that you got the vaccine, you're likely to have some swollen glands. And the interesting thing about that is, if you're due for a mammogram, we're now suggesting that you get your mammogram before you get the vaccine, or that you wait a couple months after you get the vaccine before you get it, because swollen glands in your armpit can actually be a sign of cancer. So if you get the vaccine and you get those swollen glands and you go get your mammogram a week or two later, you may have swollen glands you're not even aware of that will kind of lead you down the wrong path for more concern and more workup after your mammogram than was really necessary. So if you do your mammogram, get your mammogram before you get the vaccine, or several months later. And this slide says the most common side effects from the mRNA vaccines, but these are also the most common side effects from the Janssen vaccine and the other vaccines that are in the works. Next slide. So, the question arises, are the vaccines effective? And this slide actually comes from before we had much pickup in the general population. We hadn't had very many vaccines. So we know actually at this point that these vaccines are very, very effective. They're at least 85% protective from severe hospitalization and death, which is what was shown in most of the studies. And that has proven to be true in the real world. Clinical trials are like a well-controlled setting, and people are followed, they have to report back in. I'm actually in the AstraZeneca trial, and, they check with me weekly on any symptoms, and I'm go in regularly for blood work, and I'll be followed for 2 years. That's a well-controlled setting. So, do I develop an immune response? Have I been sick? All that stuff. So sometimes when you go out into the general use in the population, you find that the effectiveness is lower or higher. And in this case, the vaccines are very, very effective, just as effective as they have been in the clinical trials out in the real world. Next slide. So this is also a moot point. I think this might be my older slide deck because I thought I had changed that. So basically, more than 8 out of every 10 people who get vaccinated are being protected from serious disease. And so the other thing that you find once you go out in the real world is, are there more side effects? And we are not finding more side effects. You may have heard there are a few people who are, a few kinds of things that are being followed very carefully. So there's a palsy called Bell's palsy that can affect one side of your face. You get kind of a droopy eye and a droopy corner of your mouth. That's something that occurs in the general population at a set rate. It's not terribly common. But it has occurred in some of the study populations and in people who've gotten the vaccines, but not at a higher rate than it occurs in the general population. And usually, in my experience as a pediatrician, Bell's palsy is common after strep throat, for example. So it's common after illnesses. And so it is also likely to be common after COVID. So that has not, while there have been some cases reported, for example, to VSafe, it's not been shown to be above the rate that would be expected in a large population. And the same is true for low platelet counts. You may have heard of people who developed low platelet counts soon after vaccination. The most serious of those occurred so quickly, like one day after the vaccine, that actually it's not plausible that it was caused by the vaccine, because that type of illness, which is called ITP or idiopathic thrombocytopenic purpura, that takes 2 or more weeks to develop because you have a lot of platelets and you can't clear them all out of your system in a very short period of time. Plus, it takes about 2 weeks for the immune system to respond to this vaccine fully. And so it's not felt that those people with the low platelet counts, that it's really due to the vaccine either. But those reports of those two things have been present in the media. And right now, we don't think that those are going to pan out as truly being caused by the vaccine. Again, it's more likely that they're associated in time, but not causally associated. Next slide. So we've got a lot of new mutations. Houston just hit the news as having all the different kinds of mutations of concern. So these spike proteins, I told you they fit into an ACE receptor, and you can think about it kind of like a lock and key. Sometimes you have a key that is supposed to fit the lock and you have to jiggle it around to make it work. And other times you have a key that fits really well and turns that lock right away. And so the initial coronavirus was more like that jiggly key. It fit, but not really well. And so the virus had a harder time permanently attaching to a cell and causing infection. So it took more viruses to infect you. So it took a larger exposure load to cause an infection. And these mutations, basically, you can think of them as keys that fit the lock better. So that means that it doesn't take as many viruses to cause an infection because they all fit the lock well. And that would be, more infective. And they're also more virulent, meaning they cause more serious illness. And that's probably because when you get a whole load of them, more of your cells get infected. And so you get higher viral counts and you get sicker faster. So it's all about the shape of that protein. So these vaccines are based upon the initial protein, not the current, these variants that are circulating. The good news is that it will be very easy to, because we know the DNA of these variants, it will be very easy to go ahead and modify these vaccines to fit any variant that becomes more concerning or that escapes our protection. And right now, it really is not, we know that we're concerned about these variants and that it's possible for them to escape the protection from the vaccine, but that doesn't seem to be a huge ongoing problem yet. At this point, we don't have a lot of people who've been vaccinated who have actually gotten sick with these variants. The AstraZeneca vaccine does not seem to be as effective against the South African variant. But the other vaccines seem to be working well against the variants. And in particular, this new Janssen or Johnson & Johnson vaccine, a large part of their testing was in Brazil, where they have one of these variants that has been really pretty widespread. And that vaccine is still very protective against that variant. And so, so we think that the 2 mRNA vaccines and this Johnson vaccine are great choices, even though there are variants. The thing is, the variants come along when the virus infects a lot of people. The more people it infects, the more time it reproduces. And the more times it reproduces, the more likelihood that there will be a mutation or an error in its reproduction that leads to another change in the spike protein. So it's really important for us to get as many people vaccinated as possible to cut down on the infection rate in our community so the virus doesn't mutate very fast, so we can get rid of this problem. So next slide. Right now, again, it seems like we are going to be protected from these vaccines. We can update the vaccines as necessary. And it's really important that all of us get vaccinated as soon as we are offered a vaccine. So I'm going to go ahead and go to the next slide because I pretty much covered what's on that one. And I want to talk a little bit about choice of vaccine. I don't have a slide for this, but you will hear in the news that the mRNA vaccines are like 95% protective and the Janssen vaccine is like 65% protective. That's for all illness. So all of the vaccines are similarly effective at preventing hospitalization and death. And again, I want to emphasize the point that if you're offered a vaccine, get the vaccine. Don't worry about what brand it is. The Johnson vaccine or Janssen vaccine has a good effectiveness after a single dose. It's what we call an adenovirus vaccine. So they've taken an adenovirus, they've made it unable to reproduce in your body, but they've used that virus as a carrier to get that spike protein manufactured in your body. And then your body develops immunity initially, but that immunity builds for the first 28 days and actually probably for the first 2 months. And so over time, that vaccine becomes more effective, oddly enough. So most vaccines are not effective until you're about 2 weeks out, and that's true of all 3 of these vaccines. But the 2 messenger RNA vaccines are as effective as they're going to get at about 2 weeks out. And this newer vaccine, the Janssen vaccine, will continue to build in effectiveness for at least a couple of weeks after that, and probably for a month and a half after that. So that's really an interesting factor about this vaccine. So don't worry about the numbers. If you're offered a vaccine, get it. The advantage of the Janssen vaccine is that it's going to be a 1-dose vaccine and not 2. And the company is studying to see if a booster later will be helpful, but for the most part, it's probably going to stay a 1-dose vaccine. All of the coronavirus vaccines may require boosters, or just like we do the annual flu shot, because these viruses are likely to stay around. We're unlikely to be able to totally eliminate these coronaviruses. Remember that the common cold is a coronavirus. This is just a really, really nasty version of that. And so it's really important to recognize that it's likely to continue to spread around the planet and mutate over time. And we will probably be doing, if not annual, at least every 5-year shots for coronavirus into the future, is my guess. We won't know until we know. It'll take a long time to know first how long these vaccines persist, how long the immunity from these vaccines persist in our body, and how often mutations occur that can escape our immune response. And so those are questions to be answered in the next several years. But I think coronavirus is going to be here to stay. So the next question is, does a vaccinated person pose any risk to unvaccinated family members? And the answer is no, because they're not live viruses, so there's no infectious virus to transmit to someone else. We do not know for sure about nasal carriage of the real coronavirus. So if you've been vaccinated and you're exposed to somebody with the illness and they sneeze on you, you're going to breathe some of that in. What we don't know is how long that will stay in your nose and whether there'll be any sort of low-grade infection going on in your nose that doesn't make you sick because you have protection in your bloodstream. You didn't get your shot in your nose. So the protection from the shot is mostly in your bloodstream. And so that is being studied, but right now it looks like most vaccinated people at worst are going to have an asymptomatic infection and would be shedding at much lower rates than the people who get asymptomatic infections who haven't been vaccinated, which is something else we know about this virus. Doesn't make everybody really, really sick. So, so you're not at risk because of the vaccine, but you still might carry COVID into the home. So for that reason, it's important to still continue to social distance and wear masks. Next slide. So that's the big question. When can we lose the mask? You know, your whole family is probably not going to be vaccinated all at the same time. And we're all going to be out in the community from time to time. And so we don't want to carry those asymptomatic infections back to vulnerable members in our family. And even if your whole family's been vaccinated, there are two good reasons to continue masking and social distancing. Next slide. The first is that the vaccine won't work for everyone. So just having been vaccinated doesn't mean that you're 100% protected. No, none of the vaccines are 100%. So that's one risk. And people outside your bubble may not have been vaccinated. So you don't want to carry this infection to other people. And so we're trying to protect the community. You can go on to the next slide. It's become a community standard to wear these masks, and we're trying to understand when the best time is that we can stop wearing them. We estimate that we need 7 or 8 out of every 10 people to be immune in order to have an effective herd immunity, meaning that there are enough people immune that the virus has a hard time finding somebody to infect. So about 250 million people in the US need to be immune to reach that goal. And that's from infection or vaccination. And between March and November, you know, there were millions of people in the US who were infected, and it still didn't slow it down. So, you know, we have to really understand that as long as the virus can find somebody who hasn't been infected, or mutate to reinfect people, that we're going to be at risk. Right now, these mutations are one of the biggest reasons to continue to wear the mask and to maintain that community acceptance and standard of wearing masks and staying socially distant. Because these viruses are replicating more rapidly, they are causing more serious illness, and we really need to have a little time before we'll know whether vaccines are going to prevent all illness from those variants or just the most serious illness, or whether the effectiveness rate is going to go way down with these new variants. Next slide. This is my older slide deck. So during that March to November period of time when so many millions of people became ill and we didn't have community protection, more than 250,000 people died, and now we're over 500,000 people died. If we had to rely on infections alone to stop the spread of COVID-19, we expect that about between 1 and 5.5 million people would die on the way to developing herd immunity. So vaccines are the way to prevent the next 500,000 to 5 million deaths. So keep that in mind, that if you're afraid of vaccines, really your getting vaccinated is one of the ways to prevent a whole lot of people from becoming ill and dying. And so the vaccines are our way out of this scenario. And masking and social distancing are what we need to do until we get everybody vaccinated. I have a slide in this is my older version, but I had a slide about travel and when can we travel. So vaccinations, you know, may not help you lose the mask, but what they will do, you can go on the next slide because I might have a little bit about this. Yeah, no, they don't. Vaccinations will allow you, if you're the vaccinated person and you're at risk, for example, I'm over 65 and I've had 2 doses of AstraZeneca. I'm not going to travel to South Africa just yet, but you know, I feel now safer visiting my grandkids, you know, or other children because I'm protected. I may not be protecting them. I could still carry an asymptomatic infection to them, but I I am protected. So if you've gotten 2 doses of vaccine, you can consider, expanding your bubble to include other people who have gotten 2 doses or at least 1 dose of vaccine. And when we say you've gotten your vaccine, it's really being 2 weeks past a vaccine. So 2 weeks past the first dose, you're pretty safe. 2 weeks past the second dose, you're really safe to kind of loosen up your bubble a little bit, include other people who have been vaccinated. Consider some travel or visiting your relatives, but really we need to have everyone continue to be cautious. The reason I say I believe that the science shows that we're safe is even the CDC has said for healthcare workers who are 2 weeks out from their second dose of vaccine, that if they are exposed, for example, one of their children has this virus, that exposure no longer requires quarantine or isolation. So we do think this vaccine is pretty effective, not only protecting the person who's vaccinated, but reducing the chances that they'll spread this illness to other people. But it isn't time to let go of all of our restrictions just yet because of these new variants. So then the final question is, when can you be vaccinated? And doses are not as limited as they were. I don't have a cursor that I can show you, but you can see this phase 1A, the healthcare personnel, people who live and work in long-term care facilities, and adults 75 and up. And in Texas, adults 65 and up and high-risk conditions. So Texas has really moved into this phase 1C and called that phase 1B. So the terminology is a little confusing. This slide is the CDC recommendations. But what I want you to notice about this slide is it's the y-axis is doses per week that can be distributed. And we are in early March, and this upward climb of the doses that can be distributed didn't really start at the end of February, but it's starting now in early March. And that's because of this new Janssen vaccine. So we are still incapable of vaccinating everybody, but we are certainly able to now start offering vaccine to pretty much everybody who's at the highest risk of dying from this infection. So that will be the healthcare personnel and people in nursing homes, of course, but it will now include all of this phase 1C, which Texas opened the doors to that earlier. So these high risk conditions are things, again, like obesity, diabetes, heart disease, chronic lung conditions, people who have any debilitating condition that would put them at higher risk. And the website at the state is dshs.texas.gov. And that actually has the whole list of conditions, but you can ask your physician if you have some high-risk condition or you have a chronic illness and you wonder if you're in that high-risk group. So as the vaccine supply ramps up this week and next with the introduction of the Janssen vaccine, I anticipate that a lot more people will be able to get appointments and get vaccinated. And the state is rolling those vaccines out as quickly as they can. So next slide is my question slide. I don't have sorry about that. My updated slide set didn't make it to you. So I thought it did.
Well, thank you so much, Dr. Mazoon, for that presentation. Our chat box is already filling up with questions, so I'm just going to go ahead and get started with those. If I can find where we begin. Okay, so our first question is, after the second dose, people might get a fever. At what temperature would they need to take Tylenol?
Again, that's actually a really good question that leads me into another area. So a lot of times people, before they get a vaccine, think about taking Tylenol or ibuprofen to prevent a reaction. This is the first time the CDC has really come out and said that's not a very good idea. There's some recent evidence in children that if they are pre-medicated with Tylenol or ibuprofen, that they may get a lower immune response. And so the CDC has taken note of that. We don't have any evidence in adults that that's the case, but we don't want people preventing their fever. So don't take medication before you have a fever. There isn't a specific number at which you would treat fever unless you're pregnant. So if you have, just aches and pains and I don't feel well, and you find out that you have a fever, feel free to treat it if you don't feel well. You should treat the symptoms if you're feeling ill, but you just shouldn't try and prevent them. And for pregnant women, really the risk for fetal problems with high temperature is really over 102. But really any fever in a pregnant woman, we recommend that you treat. And normal temperature is, anywhere from 97.6 to 99.6 in most people. And so if you're achy and you're feeling febrile and your temperature is over 99.6, feel free to treat it.
Thank you. The next question is, for the second dose, does it matter if we get the shot in the same arm or should we do the opposite arm?
It doesn't really matter. You may want to get it in the other arm if you had a big reaction the first time. And the reaction the second time around is not likely to be exactly like the first time reaction. And I do immunization policy for all of Kelsey-Seybold. So I've been getting lots of, commentary and feedback on what kind of reactions people are getting. A lot of people are getting a pretty large local reaction, most of the upper arm on the side that they got it, that can be a little itchy or mildly painful, but mostly it's red and kind of raised, and sometimes it's there for 2 weeks or more. So don't be surprised about a big local reaction. It's not an infection. Sometimes when you have a big red firm area on your skin, that's infection. And so there have been some doctors who thought, wow, maybe that's infected, but it's not really infected. But it is pretty long lasting, and that's your immune system taking a good note of this spike protein and developing really strong immunity against it. But you may, even if you get that the first time, you may not get that the second dose. You may get, just a headache and kind of the I don't feel goods for a day. The second dose does seem to cause more general symptoms, system-wide symptoms that might keep you from going to work. So you may want to schedule your second dose when you're going to have a day off the next day or two.
Thank you. Our next question is, I've heard that Moderna is testing antibody production with a third dose. Can you share your opinion on why that may or may not be necessary?
They're doing that as part of their development of a variant vaccine, I believe. I really haven't seen much about why they would need a third dose. So if you could share your source with me, I'd be happy to look for it. But they are studying whether they need to give a booster a year from now with a variant vaccine, and that may be the third dose that you're referring to. And really, I think Pfizer is doing that too. They're all looking at these variants and trying to determine, are the antibodies from the first 2 doses going to be protective against them? And if they find they're not in lab, animals and in lab studies, then they will produce variant vaccines.
Next question, if I'm planning to become pregnant, should I get the vaccine?
I would think that it would be wise for you to get the vaccine whenever it's offered. So if it's offered to you, get the vaccine. And even if you're planning to become pregnant, it's unlikely to interfere with either your conceiving or with an early gestation. So, get the vaccine as soon as it's offered to you. And I think I saw a chat pop up saying Governor Abbott just opened it to everybody, which will only make the lines longer at this point. Oh dear. So I see that Governor Greg Abbott has just said Texas will be opening 100% to full capacity. I'm not sure. Maybe this person could help us understand because I didn't watch it clearly. I was doing this.
Does that mean not vaccine, but like restaurants and stuff like that? Is that what that means?
Oh, I don't know what it means. Yeah, maybe that that means, okay. So if it's talking about opening vaccine schedules to everybody, that will just increase demand, and we're already not keeping up with demand. So hopefully he didn't do that. If he's talking about opening up restaurants and, you know, reducing masking or any of that, then clearly this is a bad time to do that, because these variants, of which we have all 4 main ones of concern, there are actually well more than 4 variants of this virus. All viruses mutate, but these 4 seem to be particularly more contagious. The protein has changed enough that they might eventually escape the vaccine protection. So those are, that would be concerned. I'm certainly still wearing my mask, even though I've had 2 doses of vaccine, and I would not go to a packed restaurant or bar for sure.
Absolutely.
Yeah, he said it is businesses. Yeah. I think that that's being done in the interest of businesses and trying to keep businesses from failing, but I think it's not a strategy that will benefit the health of Texans.
And then there was a question up in the chat that talked about wondering, you know, how effective would only receiving 1 dose of the Johnson & Johnson vaccine compared to having 2 doses of the other vaccine. I guess people are kind of worried, you know, is it going to be as effective? I know you mentioned earlier, if you're offered the vaccine, no matter which one it is, you should take it, right? I'm assuming that's what you're going to say here now.
Yeah. Yeah, so Johnson & Johnson is continuing to study it, and they are, you know, they're aware of that difference, the 65 overall compared to the 85 for the mRNA vaccines. And so they are looking into whether 2 doses would bring them up to that. But again, the way their vaccine works is it kind of causes a chronic low-grade building up of the spike protein in your system so that the immunity improves with time, which is not true of the other vaccines. And so they're also following the people who got 1 dose to see if that immunity is more comparable 2 months out from the vaccine, then it, you know, then it might be 80%. There won't be a need for a second dose. So they are studying whether a second dose is necessary. They are studying in some volunteers the receipt of a second dose, and we'll know more in the future. But the vaccine, you know, the main thing is to prevent dying and hospitalization. If you're preventing asymptomatic infections, well, it's almost who cares, except that it does reduce transmission in the community to prevent those. So for your own safety, get the first vaccine that is offered to you, because that's really what your concern is, right? And you try and prevent the spread in the community through the mask and the social distancing until we know more. Nothing is going to stop you from getting a quote unquote better vaccine or improved version of the vaccine 6 months down the road if it's shown that it's really necessary to do that. But protection for those 6 months is really still important. So again, you know, get whatever vaccine you can get when you can get it. I enrolled in the AstraZeneca vaccine because I'm a hospitalist, and there were no licensed vaccines, and I wanted to be in the study so I could at least have a chance of getting a vaccine before I got infected. And so you know, and that vaccine is not proven to be any more. It's very similar actually to the Johnson vaccine, and it's probably going to be a little less effective than the Johnson vaccine, at least against the South African variant. And I'm still really glad I got it, and I haven't run out to get the other vaccines.
Okay, and then I believe we have one last question from Ashley.
Hi,
This
yeah,
about
I'll unmute.
children?
Yeah, of course it is. Yeah. So as I indicated at the outset, I have a 5-month-old, and I know I'm not the only one in today's presentation who has children who are not eligible for the vaccination. And I remember your first presentation, Dr. Mazoon. It made a great impact on me. You spoke about the bubble, or I'm sure it's a term you use all the time, and now I'm not remembering it. But this idea where we have everyone around the child vaccinated as a way to, yeah, the protection of it all. And so, you know, there's certain things that I would like to do. I live far away from family, and I would like to be able to travel with my infant son on an airplane. and things like that, and wondering, and of course I've had these conversations with my own pediatrician as well, but wondering what your thoughts on the safety of and maintaining the safety of a child.
Yeah, so a 5-month-old is too small to wear a mask, right? You can't protect them that way. And most of the airlines are not allowing, their center seats are now taken. They're not spacing us out. The filtration in an airline is pretty good, but there have been numerous reported outbreaks on airplanes, even with people masked, within a few rows of each other. So I don't think it's really very safe. The thing is, a 5-month-old is likely to have an asymptomatic infection if they get infected, but who else are they going to infect? And not all 5 months old are asymptomatic. So we do have these children who are having these terrible immune system breakdowns and in the hospital and getting really, really sick. So the solution for the children really is to try and make sure everybody around them is vaccinated. So if you're breastfeeding and you've been vaccinated or you've had COVID, some of that immunity will cross to the baby and will protect them for a while. It'll protect them while you're breastfeeding, at least for a while, but it may not be complete protection. So it's a real difficult question, and it's a question for the whole community. Some 20% of the US population is under 16. So, that's a whole group of people that can't be vaccinated yet. How are we going to get herd immunity of 80% if 16% of the people can't even be offered the vaccine, or 20% can't even, be offered the vaccine? So it's really a problem. And so for those of you who have children who are 12 to 18, the Moderna vaccine is recruiting people, children for those studies. So particularly if your children have asthma or obesity or diabetes or something, you can get those children enrolled in the trial and hopefully get the vaccine arm and not the placebo arm of that trial and get them vaccinated. It's really, there's no good answer to your question. I think if you're traveling with children and you're traveling, for example, if the grandparents have been immunized, but you're not immunized, you could get tested for COVID. I don't think I'd subject your 5-month-old to that. If you test negative and you traveled in a car, took your bubble in your car with you and figured out how to not stop at too many places on the way, I think, you could probably visit. But and the child would probably be safe because the adults, that you're going to visit have been vaccinated. But I don't think it's time to visit unvaccinated people, particularly not in, areas where we know there's a whole lot of transmission occurring, like Southern California or, the Dakotas or whatever.
Oh, absolutely. And this is all anticipatory. So we wouldn't even, do anything until both my partner and I are vaccinated, as well as the family that we're going to see.
Yeah. Well, then at that point, your 5-month-old is likely to be safe because you guys are protecting the 5-month-old. But you wouldn't want to take the 5-month-old, into the store on the way. In the car travel, it'd still be safer than the airplane. I think, you could move the baby to the window seat. You guys are trying to kind of create at least some distance between the baby and other passengers would be your only option on an airplane.
Thank you.
Well, thank you so much, Dr. Mazzoon, for your time. We really appreciate it. This was a wonderful presentation. We had a lot of really great questions. For those of you who maybe think of a question later, or if we happen to miss your question, you can always email those to us at healtheducator@thewomensfund.org, and we will work to get your questions answered. Following this presentation, I will be sending out an email, and it will have a survey link. If you could please complete that survey for us, provide us with feedback, let us know how we're doing, what you liked, what you didn't like. It would be greatly appreciated. Lastly, I want to mention, I mentioned our website, thewomensfund.org. There you can find more information about who we are, what we do, and upcoming events. So tomorrow we have the final presentation of our Heart Health Awareness Series with trainer Heather Scholl. And we have a Shopping on a Budget presentation on Thursday. Friday, we have a mental health and nutrition presentation. And then Saturday, we have our first doc talk of the year over COVID-19 vaccines, truth, myths, and question marks. So I highly encourage all of you to visit our website and register for our upcoming presentations. That is all that I have for you all today. I want to thank Dr. Mazoon once again for taking the time to give us this presentation, and I hope you all have a great rest of your week.
Thank you.
Thank you.
Thank you.